Niramai is a company that has developed innovative AI-based breast cancer diagnostic solution, which helps in detecting breast cancer early and thus save lives. So today we are all here. I'm sure you've heard it on many other platforms as well. October is a month for breast cancer awareness. And although we definitely believe the awareness should not be limited to October alone, but this is as part of our endeavor, we have these webinars every month where we talk about women's health and the most common cancers affecting Indian population. It just so happens that October is also the month of breast cancer awareness. And rightfully so, an entire month is dedicated to breast cancer, which is the top cause of cancer in our country. Around 178,000 women were diagnosed with a new case of breast cancer in 2020. And this is just last year. And in the same year, 2020, around almost 90,000 women succumbed to the disease. And we believe this very low ratio of every 2 women who are detected of breast cancer, 1 woman succumbing to it is mainly because of lack of awareness and not able to get yourself screened at the right time. So early detection is important to get prompt treatment, which will ensure a better survival rate. And to address this, Niramai has developed thermalytics, which can detect cancer long before a lump is felt. It's a painless and the radiation-free test. It is non-contact, completely privacy aware. For example, this is the booth in which the screening is done. The woman who needs to get screened is inside the booth. A technician sits outside. A technician doesn't see, touch, or feel the woman who's getting screened. So it's a completely privacy-aware test. It's a dressing room experience, and it's also affordable. And because it's a very small device, so it's also portable, and it's powered by artificial intelligence. It's applicable to women of all ages and men too. And it is also available now at the comfort of your home. You will get on the charts, you can see that there will be information posted in time to time on how to get this breast health screening in your house. With that, I think we will now start with the webinar. Our doctor today, who's going to address the burning issue, is Dr. Garima. Dr. Garima, thank you for joining us, but I'll let Dr. Tanveen do the detailed introduction of your very illustrious career. Thank you.
Thank you, everyone. Welcome, Dr. Garima. So for everyone who's joining us now, this is a little introduction that we could make from all the experience that she's given us. Dr. Garima Mehta is currently a consulting surgeon and professor at All Indian Institute of Medical Sciences, or AIIMS, at Udaipur. Her long, illustrious career of over 35 years has seen her in various roles, including professor and head, R&T Medical College, Udaipur, where she also started the breast clinic way back in 1992. She was also a general surgeon in the Kingdom of South Africa, resource person with the World Health Organization, coordinator at the Atlas trial, which is an international multi-center trial on tamoxifen CTSU, Radcliffe Infirmary, Oxford and UK. She was also a part of the national multi-center trial on Pruluton depot of breast cancer patients by Tata Memorial Hospital, Mumbai. Her keen interest in breast cancer led her to obtain a PhD in clinical and biochemical aspects of breast cancer. She is also working on lymphedema support systems for patients. She is the recipient of prestigious National Scientist Award, member of National Academics of Medical Sciences, MNAMS, in 2003. She published many research papers on breast diseases and has delivered many guest lectures in various national conferences and CMEs. She has also helped create breast cancer survivor groups, the latest initiative being Garima Can Foundation, to help all the breast cancer patients and survivors. Thank you so much once again, ma'am, for giving us the opportunity to talk to you today and for delivering us this lecture on our platform. We welcome you and we hope to have a very fruitful conversation. Ma'am, you're
Thank
on
you,
mute.
Dr. Tanveen. Dr. Garima, I think you're on mute. So just before we start off, this webinar is also in collaboration with the Garima Khan Foundation that Dr. Tanveen didn't mention. It's a breast cancer survivor group, which Dr. Garima has initiated, founded. So over to you, ma'am. I will share the slides on my screen. And you're still on mute, ma'am, by the way.
Can you hear me?
Yes, now you're audible.
All right. Thank you very much, Tanvi and Dr. Lakshmi. I'm honored and humbled to see your and hear your introduction. Can I see my slides? Okay.
Can you see them, ma'am?
Yes,
No?
I can. Okay. Hello, everyone. I bring a lot of greetings from City of Lakes, from Rajasthan, Udaipur. I've been given task of talking about breast cancer risks and its prevention. I'll try and focus myself on the topic I've been given. We can always talk about something else later on if they want me to talk about something else. So can I have a second slide, please? All right. So as we know that the cancer is really devastating disease, known to mankind since eon. I remember when I was writing my PhD thesis that there were some references regarding this disease even during Ramayana. I'm not sure how true it is and how it is the fact of it, but I remember reading it. So it is not something new which we always think it is. It still remains elusive in certain aspect of it till today, despite uncounted researches and understanding of the disease is still not completely done. It brings a lot of physical, mental trauma as well as financial ruins to the patient. It doesn't come alone to the patient. It brings whole family in to the very distressed situation. We know we are quite a huge number of population. Therefore, even a small number brings many fold high load of cancer patients. Prevention of the disease, if you talk about, it is defined as procedures through which individual can be prevented of having particular disease. We categorize prevention in three categories. First, primary prevention, which means before health is affected because of some reasons, we stop the disease. Very small and easy example, I'll give it to you, that if we get safe drinking water, the waterborne diseases will be prevented. Very simple. Like if you don't use tobacco, chances of cancer is being extremely low, especially of lung and head and neck cancer. So that is known as primary prevention. Secondary prevention is when you identify the disease early, like screening, like Dr. Tanvir was talking about, that there's a thermolytics can pick up tumor very small when it doesn't have time to grow large. So that is known as secondary prevention. Tertiary prevention is when we try to control the sequences or sequelae of the disease. For example, if patient has got ischemic heart disease, patient is advised to go for coronary artery bypass or a stent or something, so that the problem of heart disease is not go beyond our control. So these are the type of prevention which we talk in our medicine. Second slide, please. There are a lot of things which we think we know, but in India, we have got very unique feature of breast cancer patients. We do know that the breast cancer incidence is increasing on 2 to 2.3 to 3.2% every year on annual basis for last 30 years. Rising numbers of these cases come most of the time 40% to 45% with the late presentation, meaning that the tumors are quite big to be treated completely. This late presentation can be due to so many reasons, which we may talk about later. And the troubling part is that these tumors are aggressive in nature, because we have got 30 to 40s, third or fourth decade of cancer patients who are approximately 30% or 40%, which is quite a huge number. There was a very nice study came that it changed. It showed the change in breast cancer trend in 25 years. As you can see on the slides, that the incidence increased from 2% to 4% in 20 to 30 years age group of patients. And similarly, it increased to almost double, more than double, in third and fourth decade of the disease. Although around 70% of the patients were of beyond 50 years. But these two categories, 20 to 40, or rather I would say somewhere around 30 to 40, it is approximately 25% of patients, which we don't see or we don't read in the West literature. This trend is still continuing, which is really bothering. This can be explained through the younger generation of India. I suppose this can be one of the important reasons why we see a lot of young patients. Next, please. Next, please. I would like to stress few points before we go to the facts regarding breast cancer. In my personal perception, for past 25 to 30 years, despite very dismal picture of breast cancer scenario, still we see a lot of positive things, in the sense the breast cancer patients who are living longer these days than when we saw it 30 years back. Now I can put few fingers on points, like awareness is increasing slowly. It is slowly but steadily. Small thing, patient comes to you immediately. Second, the knowledge of doctors population is increasing gradually. Understanding of cellular level characteristic of the tumor is better known. And despite deficiency of doctors available, specialists are comparatively easily available. So the treatment is done on the scientific basis, on not on whimsical basis, which we used to do it before. General health of the population is improving. Better hygiene, better nutrition, vaccination drive, availability of healthcare facilities. Even in small villages, you will see ASHA workers, Anganwadi workers, who are really working very hard to vaccinate patients, to tell them the hygiene. A lot of things are going on in the country, and I'm very happy about it. And things are not as bad as it looks like. This cancer can also be increasing because of increasing age. Longevity of the population is more. Population in number is increasing tremendously. And of course, the last but not the least, westernization of our lifestyle. These are the few facts which we cannot ignore, that they are good part of our health system. The breast cancer is commonest cancer, as we know all. But the 80%, 90% of the patients remains benign, means tumors are not cancerous. So if 80% breast tumors are not cancerous, these are the patients where we miss out on malignant patients as well. Like if patient is having lump, probably people will say it is very common and it is milk gland and it is nothing. So patient, by the time comes, the tumor increases in size. One more important part about it is that 90% women picks up their own lump for the first time. So you are your own best survivor, savior. So you have to be careful and you should know your breast very well. And last, lifestyle changes reduces the breast cancer. So again, it is in your hand. Next, please. These are just statistics. We all know that it's a very common disease. I was surprised to read that in USA, 50% women consult surgeons for breast diseases. But similarly, it is in my practice that if I see patients, probably everyone will be touched by these diseases, if not cancer, but benign. It's common. If you see the statistics, we are luckier in the sense, if 10 women is born in USA, 1 out of 9 will become malignant. While in India, average, you can say that it's if 45, 50, 60 women are born and live for, say, 80 years, it is less in number. The average age is younger than the West, and we are increasing slowly and gradually. Next, please. As always, already told you that it is lot of breast cancer load in the country, and this swing towards young patient is bothering us a lot. Now comes the point, what is the most important, that every patient who comes with the history of cancer usually says, ma'am, we did nothing. We had good life. We are eating well. We are not drinking. We are not smoking. Done nothing wrong. Why am I having cancer? So we are very on the edge of saying we don't know. I always say I don't know, except that you are women and you are growing old. So aging is important. Gender, of course, is important. Male do get breast cancer, but it is just 1% of the incidence they have got. If we see 100 patient or 110 patient, one male will come with the disease. Cancer families are known, especially if breast cancer was found in sister, mother, daughter, bua, masi, nani, dadi. That is known as, if it is more than 2 members of the family, it becomes sort of cancer family. There are few things which you can change, modify. There are things which you cannot change, like your family members, like your age, your gender, your menstrual history. It is not in your hands. Similarly, it's a genetic mutation which you cannot change. But there are certain things which we can change, and it is under our control. Next, please. So when we have risk factors, they are non-modifiable and modifiable. Non-modifiable, we don't talk about it because we can do nothing about it. But modifiable, we'll talk again in details that what can we do about it and what kind of changes can bring you better life. Next, please. Breast cancer is a lifestyle disease, and it has multifactorial reasons. If patient has early menarche and late menopause, anything which increases the menstrual cycle number and the span, it increases the risk of breast cancer, because breast gets exposed to the estrogen hormones. Longer the menstrual period in your lifetime, more chances that you are going to get malignant changes in your breast. Similarly, parity. If patient is having multiple children, chances of cancer is less, because many times cycles are broken. So number of cycles are less. Aging is always a risk of cancer. Most of the cancers happens either less than 5 years or more than 50 years. So if patients are having more age in population, chances of this being high. Diet is extremely important. Obesity is bad. Sedentary life is always bad and brings a lot of non-communicable diseases. As we all know, alcohol, smoking, they're all risk factors. Next, please. As we said, there's only few points which I'm going to stress here. Strongest risk factors of developing breast cancer includes being female is there. Who have developed the breast cancer is going to have second breast cancer on the breast again, because the risk remains the same. The important thing I would like to say that in US, after 92, 93, the trend was of having less breast cancer incidence. And they try to study that any supplementary hormones like oral contraceptive pills or hormone replacement therapy, which was very common in US and UK, they were using absolutely uncontrolled methodology. And when they realized that this is something is going to harm us, they stopped and reduced the number of years when they were receiving OCPs or hormone therapy. And suddenly they saw that after a decade or so, the breast cancer incidence became low. So we have to be very careful. If we suggest patients to take oral contraceptive pills, take it for shorter duration and don't take it continuously. If you discontinue after 5 years, probably you will have again reduced chance of having breast cancer. So one population has to be extremely careful about it. Next slide, please. Similarly, as we say that full-term pregnancies lead to the differentiation of breast epithelium, which is very protective to the breast. Obesity gives the fat, especially central obesity, which is common in Indian population, Indian women, very classical, below waist, they are all broad than the upper side. And this gives a lot of estrogen. Even if patient is menopausal, this fat cells supplies estrogen in estradiol form and increases the risk. So if central obesity is low or less, or patients are little more, doing exercises, yoga, and it increases the metabolism and reduces the fat cells, therefore reduces the estrogen hormones. So pregnancy is quite protective, lactation is protective, obesity is really bad, and of course, menstrual cycles, which we cannot change, is there. Next, please. So once we know these are the risk factors, now you would like to know that how do I know that I have got a cancer? Few points to stress that you must know your body very well. You must know your breast very well. Like we know our face. We see our face on mirror every day. So even a small pimple or small anything, any lesion, suddenly you can see it because every day you don't see it. It means when you know your face, you know there is something abnormal going on. Similarly, you should be very aware of your breast anatomy, its shape, its size, its architect, its skin, nipple, areola. And if you know this is the normal, immediately you will realize there is something abnormal. So my submission is any abnormality which you see for at least a month or so must consult a doctor. Don't try to analyze yourself or talk to your neighbor or Google it. Examine yourself monthly. And if you feel any thickening of the skin, any lump, any, crumbled up mass, or there's a change of size or shape, any dimpling, any coarsity of the skin like orange peel, or any wound which is not healing, which should be healing slowly, but definitely, surely, it should heal. But if it's not healing ulcer, if there is some kind of puckering is there, retraction of the nipple is there, level of the nipple is different than the other one, never ignore it. Must consult the doctor. There is no harm consulting a person who knows about the disease. One important thing is nipple discharge. Nipple discharge is usually very physiological. Physiological means it is a normal entity. If it is happening bilateral, both the sides, if its color is like water or greenish, don't bother about it. But if it is on one side, if it is coming from one duct, and if it is persistent, and mostly if it is bloody, never ignore it. So these are few points which I would say that you should be very careful about. Not very commonly, but we find Paget's disease of the breast, which usually affects nipple. There is a persistent scaling, there is persistent ulcer, and you feel as if the skin is coming out gradually, and there's a distortion of nipple. That indicates many times that there is a lesion just below the nipple, which you cannot feel it otherwise. So these are the symptoms which are very important that you try and concentrate and consult your doctor as and when you notice it. Next, please. When you have a disease process, when you have a lesion, you try to know what shall I be doing. First, consult your doctor, and then you have to go through few things. These few steps are suggestion by WHO that how early diagnosis can be done. Although these things are not directly related to the patient, but a very important thing I thought was there in this WHO guidelines, that you must improve your awareness, your family's awareness, and your children's awareness. It's not harmful that everyone knows what is right and what is wrong. You must know where to go, where not to go. And if you have got oriented clinics, like if you feel that it is breast-related disease, you can go to gynecologist. Surgeons are also good. And of course, if you have suspicious of malignancy, oncologist should be consulted. So literacy is extremely important, that you should know about the literacy of the disease. Next, please. Second is that we should all equip the skills to identify the cancer, which includes doctors, which includes nurses, which includes paramedical staff. Everyone should know how to go about it. In India, very typical system, I don't know how it is other part of the country, but I have seen in Rajasthan various part that everyone is expert here. So please don't do that. Go to the appropriate clinic so that you can have proper treatment. Next, please. Society should create some kind of logistics of ensuring that anybody who is not well enough, resourceful, and illiterate, we should try to have society and cultural barriers are there. You know, sometimes patients are not very comfortable. Yesterday, we went to village to have a cancer awareness camp, and there were around 50 ladies. Everyone was having covered face. It was hardly we could talk to them. They were not interested in having conversation. And the moment the breast comes in the field, they will all doubled up and not interested in having examination. With difficulty, we try to do these thermalytics screening. But once they started going through the screening, everyone opens up, and we could pick up 2 diseases. So it is not only you and me, it is the society also which has to be taken care of. Next, please. It is just a small, I found it very interesting and very annoying also, that in India, we don't get to be investigated or to be screened annually. Not even sonography people go for. But, you can see USA, that mammogram is being used left and right, and, center using a tremendous amount of money, and which may not be even useful. Next, please. So once patient has got symptoms, this is important to know what I should be doing it, or what I should be advising them. Very strong point I would like to make. Please, anyone and everyone, don't get mammogram done without asking any doctor. I get a lot of girls, young girls with mastitis, with myalgia, 2, 2, 3, 3, 4, 4 mammograms in their hands. They are not good. They are not sensitive in younger age group. So please don't get unnecessary investigation. That is the humble request to the population as well as to the doctor. Don't advise patient less than 35 or 40. And that too is with the important significant symptoms. Next, please. So comes the next, that before you go to the doctors, you must know that how I do the physical examination. The physical breast examination should be done by the doctors, but patients should be doing self-breast examination. So these are the guidelines which we tell healthy women to go through it. After completion of menses, patient should have a physical breast examination after 40 years of the age. Baseline mammogram, I say 40 is little early, 45 should be fine unless patient has got very high risk where you can have 35 years of age for mammogram. Ultrasound is a good tool to evaluate young patients. I think it's really good, and a good ultrasoundologist can pick up small tumors very easily. I have put few queries with the thermalytics because my experience is really, really short. I have seen only thermalytics reports probably in 30, 40 patients. So I'll keep this, in reserve unless I become more experienced and a little sure about it. But it is extremely important if it continues to remain on and be approved to be a screening tool. So the hats off to the thermalytics and Niramai group to have come out with this. Next, please. This is just, to tell you that we have treatment, though this is not our topic of today, but I thought just to have a little bit of complete overall picture of breast cancer. There are two important parts in treatment of breast cancer. One is local control and second is systemic control. Why I have put this slide here? Because local control is extremely important. If patient comes with the advanced disease, then you can imagine that local control is very difficult to get. And then comes the role of systemic control. If tumor is less than 1 centimeter, 1.5 centimeter, probably we don't need any systemic control. We don't need chemotherapy, we don't need immunotherapy. Of course, hormone therapy is required, but then we don't need a lot of treatment, so which becomes less expensive. Next, please. In that same breath, these are the symptoms for general cancer. Population must know that if this caution word you remember, if any sign symptoms which is mentioned here are there for more than 6 weeks, please consult your physician, family physician, doctor, or anyone. Any change in bowel habits, if you are having regular bowel habit, loose motions or diarrhea is bad. If you are having normal urination, if it changes, consult. And it should be persistent for 6 to 8 weeks. Any wound which doesn't heal. Unusual bleeding for unusual sites should be consulted. Indigestion, which is long, difficulty in swallowing, obvious change in wart and mole. There's a small mole there and it is in size, it is itching, it is bleeding. Any nagging cough should be consulted. Next, please. So, very basic of body milieu or functioning of the body is that this is something which is, it starts with the inflammation. Very nice chapters are coming these days of inflammation. Any disease, any body inflammation, if it is chronic and it is low-grade inflammation, if it is persisting, it turns out to be chronic diseases like cardiovascular disease, cancer, diabetes. Any patient who has got chronic inflammation can turn out to be a malignant patient after a certain period. Next, please. So this health disaster, next, please. This health disaster should be really taken care of, and little bit of medical and lifestyle modification can protect you from this inflammation and turning this into malignancy. Next, please. So this inflammation can be fought by yourself. There are 6 important points which will reduce this inflammation. This will make you healthy, and this will make your chances of having malignancy very, very low. You must see these weight wala photograph a little bit. In 1980 and 2014, you can see the weight increase is almost 24 pounds. So in last couple of decades, we have become fatty people. Stress, no end. Everyone is stressed. Diet is so bad. Healthy diet we forgot. We don't move at all. If we have to move for 1 kilometer, we will take our bike, car, and then go. Sleep is very disturbed. Tobacco, I think, is gradually becoming less and less common. But rest of the things is important to have prevention of any other disease. And this is the next, please. And this is the diet, which is extremely important, that what you should have, what you should not have. Unhealthy dietary fat is very bad. You have to have at least 20 grams of fat in some form, but more is not good. Plenty of fibers are important. Whole grain, fruits, vegetables is extremely important, because fibers, when they are ingested, they take the toxic fluid of gut and the roughage along with the feces, and it reduces the toxicity of the body, toxins of the body, and it produces good bacteria and vitamins. Sugar is absolutely poison. Try to reduce or minimize it as much as possible. Tobacco is capital no. Cut down on red meat. These are the diet which are very important, and anyone and everyone should be careful about. Next, please. This is important part of it, that self-breast examination should be done monthly. I'm sure if you go online, we all know there are plenty of videos and text are available that how to do self-breast examination. Unless you do it seriously, you are going to miss out on small lesions. You have to be extremely careful that how to do it, and you do it regularly. Half-hearted work is not very fruitful, and sometimes you may have probably false notion that you are good. I know a few doctors who were doing regular self-breast examination, but because they were not careful, they were not doing systematically, they miss out and had advanced cancers, unfortunately. So these are the important point which I wanted to talk about, because I'm not sure what kind of population I'm talking to, but I thought just have a small overall of breast cancer. Tanvir, next, please.
Thank you, ma'am. I think the presentation got over.
Mm-hmm.
Oh, sorry. I'm sorry.
Hello? No, it's okay. No, this is fine. So what I'm saying is there any question?
Yes, we do have questions, ma'am. So one question is, does a history of PCOD increase the risk of breast cancer?
Sorry, say it again.
Does the history of PCOD increase the risk of breast cancer?
Not exactly similar way, breast cancer, but most of the time this is a hormonal imbalance. PCOD is because of hormonal imbalance, and there is a lot of hormone therapy which is being given to the patients. So I'm sure when you take the medicine, you know what you are taking, how long you are taking, and I have seen a lot of repetition of the courses they are being given. So this is something you have to tell your doctors, that or gynecologist, that how much you should be taking and how long you should be taking. So as such, it is not risk. Breast cancer risk is increased in ovarian cancers. It increases in patients who have got familial trait of malignancy, prostate, colon, ovary. Yes, it is increased, but not PCOD.
Thank you, Dr. Garima. Dr. Geeta, I see you have raised your hand.
Hello?
Yeah. Hello, ma'am. This is Geeta here. Wonderful talk. Excellent. I think one of the best talks we have had in these.
Oh my God. Thank you so much, Geeta.
So I had one question. You've been, seeing breast cancer patients for almost 25, 30 years. So, in your perspective, when you talk to the patient when she comes in and she comes to know she has cancer, is there something that you felt like she could have done this and should have found it earlier?
No.
Or maybe you know that they always come with self-breast examination or accidental examination of a lump. Like, so any learnings about what they could have done differently?
Geeta, there are 2 points I would like to mention. One is, it is very well known that self-breast examination is not scientifically proved to be good.
Yes.
To pick up tumor. That's very large study going on, still going on in Tata, in Mumbai for last 20 years or so. Self-breast examination is not done properly, point number 1. Point number 2, most of the time they don't know how to do it.
Yeah.
Point number 3, many things which they are not normal, but they cannot pinpoint whether they are abnormal. There's a two difference, because breast is very dynamic structure. It keeps changing. So today, suppose I take the examination when I'm in middle of my cycle, it will be feeling differently. If this is done premenstrual, it will be feeling totally different. So proper examination by patient, in complete examination by patients. This study which is going on in Tata, they have concluded almost. They are still following it up. The self-breast examination doesn't pick up tumor very frequently. It is usually accidental finding. Suddenly you are taking bath and patient says, oh, from there where this comes. This is about the picking up the tumor. As far as saying to the patient is concerned, when patient comes, the person is traumatized.
Yeah.
That time talking about past is not very intelligent thing to do. That time they need to be just, very comforting and tell them little positive things, tell them that, it's curable in many circumstances. If you give treatment, it's very, very tricky point to give this bad news to the patient. It should always be done when it is confirmed. Never ever I do that. The suspicious lesion, I never tell them that can be cancer. So 1, never disclose it unless it is confirmed. 2, always give it this bad news with the close relative with them. Close means close, not friends, not cha-cha, mama. It should be husband, mother, father, brother, son, daughter. Close family should be there when you disclose this news. And I never...
To the patient?
To the patient, yes. We have to disclose it to the patient because patient is the one who is going to undergo everything.
Sure.
So you have to be, but they should be along with the family members. And third thing, never open all the cards in one go. You have to give them slowly, but steadily. Each and every point has to be mentioned to them. Let me give you example. When patient comes, I talk to them, I give them investigations. They will insist, please tell me your clinical advice or clinical finding or clinical diagnosis. I never give them, never ever. Because few times you will be wrong, So I'll just tell them to go for investigation. They come back with the investigation. I always advise them to come with the family members, which is near dear, who are deciding people. Because most of the time, female can never decide by themselves that what they want to do. Whether they want to save their breast, they want to have breast conservation, they want to have what, they will never be able to decide. So the deciding people should be with them. Then I will always tell them that you go, think about it, what you want to do, where you want to go for surgery, or if it is chemotherapy, you do this. So gradually you have to, tell them the whole story. Never frighten them that it's devastating. Tum pehle kyun nahi aaye? You should have come earlier. You could have, pick up earlier, because that guilt is always there in their mind. They know that they are late. So we should not hurt them more than what they are already hurt. That's how I give them the advice. And once it is treatment is given, patient is gone, follow-up is extremely important. Continuous follow-up, their physiotherapy, their rehabilitation, their social, physical, familial rehabilitation is extremely important. So for me, it is a total package which you have to give it to them, but never say that you should have done this and you should have done that. This is the past, gone. That time is gone. So we should not. But yes, to their family members, to their children, to their sisters, we must tell them again. But usually I call them later on. When this person is okay, gone through everything, then I call them and then I tell them that that's what you should go for screening and for sonography, or if need be, mammogram or whatever. That's how I take it.
Thank you, ma'am. I think this is immensely helpful, because when we find a person who is BI-RAD 4 or 5 during thermolytics, also how we actually talk to them, and we don't say it's cancer, but we just tell them to go for a follow-up ultrasound, or depending on the age.
Geeta, there's one more point. Like, these technicians, they are overwhelmed. This happens with me also, that they were talking amongst themselves. And patient is intelligent, they grasp the point. And you have to be extremely careful. And we should teach these volunteers as well as these technicians that how much they should talk and how they should behave when they are doing screening. They will talk about, kuch abnormal lag raha hai. There's some redness there. There's some, the person is listening. And probably, yesterday we had this screening camp, and there was one young girl with this lesion, and there was totally hot nodule. I didn't examine the patient because it was screening procedure. I said, I'll examine her later on. It was an abscess. But that talk, scared that girl out of, so she just almost fainted. So we have to be extremely careful, extremely sensitive, yet very firm in your advice that you must consult a doctor. We see abnormal finding. I don't even advise that screening person should say that go to sonography or mammography or whatever. Go to the doctor concerned, let them examine you and let them advise.
Sure.
But don't take it long to get the consultation.
Okay.
My take is like this.
Oh, this is excellent. Thank you so much.
Yeah.
Thank you, ma'am. There's a question on inflammatory breast cancer. I think because you mentioned the word abscess, I think the question came up. So they're asking, what is inflammatory breast cancer? We have read it being common.
It is not common. Inflammatory breast cancer is not common. It constitutes probably less than 5% of breast cancer. Commonest is infiltrative duct carcinoma. Duct carcinoma is commonest type of cancer. Inflammatory cancers are not very common, and they don't behave very good. They are aggressive tumors, difficult to diagnose, and many times even co-ordinated biopsy doesn't help us doing the diagnosis. So it has to be, if diagnosis is not done because with the co-ordinated biopsy, we advise some kind of incisional biopsy along with the skin, because inflammation is in the subdermal area, skin inside. So it's not very common. I think I have got my personal series of 2,500, 2,600 breast cancer cases. I must have seen 10 total, not much.
Okay.
So it is not common.
Okay. The next question is, are genomic tests for breast cancer advised in any situation in India?
Now, there are a lot of people who are very keen on genomic testing. As far as I am concerned, I'm not for it. There are two important reasons why I'm not for it. If you say that you have got positive genes or BRCA1-2 positive, then what? Are they ready for bilateral mastectomy? Will you advise them to go for it? Will you advise them to go for oophorectomy? So when you advise any test, you should know that what next question is going to come, and what answer I'm going to give. You make a person's life miserable by getting one test done, which I'm not sure. 80% positivity is there, suppose, of breast cancer in BRCA1-2 positive cases. You will scare 100% patient. Do you understand what I'm saying?
Yes, ma'am. Yes.
So as far as I am concerned, I will go for it if patient is young, patient has got aggressive tumor, patient has got microcalcification extensive, DCI's component very high, grade is nuclear grade is very high. There's some family history. Yes, I will go for it for two reasons. One is if patient has got positivity, I will go say that go for bilateral mastectomy and oophorectomy. It's fine. But very select few patients should be there for this kind of study, unless it is some trials going on or some research is going on or some, something is apart from treatment is there. Yes, you can go for it, but practical purpose or for routine, for me, no. I'm not for, because I know a lot of cancer families in my records. Bilateral mastectomies I have done probably 15, 20, not much. The rest of the patients were fine. If I would have asked for genetic test, probably bilateral mastectomy would have been very, very high. Okay. So it has to be a moderate path, middle path, increase their knowledge, reduce their apprehension, their scare, their obsession to the cancer, but then don't ignore it. Their follow-up is extremely important. You should remain in touch with them. If they don't come, I call them many times that I have not seen you, all well. So that's how my practice goes.
Thank you, ma'am. There are a couple of more questions, so I'll quickly take them. Do we foresee any vaccine for breast cancer like
not
we
yet.
have for
Not yet. Not yet. There are few in the pipeline, but I think it will take few years to come. There are few places they are working very hard on it. But yesterday I was asking these ladies, and there were some students also, college students also. They have not even vaccinated their children, and the girls are not vaccinated for cervical cancer.
Okay.
So it is there, but still people are not aware, they are not being advised, they are not being given. So in India, what we have, we should utilize them to the maximum. We are not utilizing whatever we have got to the maximum. But in breast cancer, not yet. We have to wait for
right point, ma'am. We need to utilize what we have before we
and utilize it properly, not misuse it. We are misusing whatever we have got. So that is something very important. We have to be answerable to what investigations we advise, what advice we give. I should be answerable to it. So that's what I'm thinking.
What is the frequency of men having cancer?
1%.
Do we see it in young?
1 to 1.5%. Yeah.
Okay.
And
in younger or older men?
No, mostly it is around 50 plus, 50, 55, 60. And everything is almost same as women.
And do they have a family history?
Not always, as not female, as women. Yeah, no. I have got few male also, but they are as endemic as women.
I'm just curious. You said you've seen male cancers also. How many cancer patients have you seen or treated, just for the benefit of our audience as well?
Probably I had mastectomy of 8 men in my record, 8 or 9 maybe.
Okay. And total, I mean, I know you can't put a number to the number of cases you've seen in your lifetime, but in general,
my records are not bad. I have got records of cases. I can still count probably 2,000 plus cases I have operated. I've seen breast cancer, and without, if you say breast clinic, must be 12,000, 15,000 documentation you can find in my computer without malignancy as well. So I'm sure more than 2,200 or so breast cancer patient I have records. If you want to use it for any research, you are free to do it.
Thank you so much, ma'am. That's an overwhelming number.
I'm
sure.
not going to take them with me to
I think that would be very useful, ma'am. Because actually, it's very good. It'll be very useful because we have developed a breast cancer risk assessment tool, and mostly based on US data and, of course, our own data wherever possible. But I guess we can fine tune. It's a free tool that we give, so it'll be great to see.
Sure. If you need the the data, whatever I have got, I'll share with you. Use it as as you like. I have absolutely no issue.
Thank you.
So in India, because in Udaipur is comparatively not a urban population. It's a sort of in between rural and urban population.
Mm-hmm.
But majority of the patients are probably 40% are rural. So quite high number of rural population.
There's a question linked to that. They're asking, what are the ways we can improve the country awareness in country like India, especially in rural India?
That's what we are doing.
No, so you did mention about the cultural barriers.
Rural people are equally intelligent. They are aware. The problem is that they are not being guided properly. The resources which we have, government has done tremendous job, I must say. 10 years back, patient will die of disease, have no money, no treatment, nothing. It was a BPL Yojana, but 40% patient has to pay. So 40% of chemotherapy is a big amount. But now with this Ayushman Bharat, and everyone is getting treatment. So almost 3 lakhs to 5 lakhs rupees for chemotherapy is good enough. So I think we are doing pretty well. I'm very happy with the scene. I'm very optimistic. It is going to go more than what I expected to go. And rural people are really intelligent. Yesterday, they were like, the queue were there. Hamara bhi test karo, hamara bhi test karo. I said, initially you didn't come. Now we have to pack and go. So they were really curious to get them tested. So I think they're intelligent. They're doing very well, pretty well. The only thing is, few places, they just don't bother about it, and they will see mere bachcha chota hai, mere bachche ki shaadi hai, mere delivery hone wali. There's a lot of things in mind of female. So I had to fight with them, and usually I fight with their husbands and their sons and male people, But I think they are okay. We are doing okay. Not bad.
I think that's a very positive and an optimistic note to end this seminar. It was a wonderful discussion, ma'am. Like Dr. Geeta mentioned, probably one of the
Geeta, I would suggest you one thing.
Yes,
one time we will do something on nutrition.
Sure.
I tell you, to me it looks like we are missing very important part of diet in malignancy. Very important part. In India, there are two types of malignancies, two types of communities. One is khate pite ghar, second is emaciated. In Udaipur tribal belt they are absolutely below average weight, and they are having cancer. So probably this mutation is because of malnutrition. That's my belief. So I think we can have coverage. Not treatment part is not important at all. I think that is something I'm not interested. You can ask someone else to talk about it, but general well-being, diet, health, general talk we can do once.
Sure, definitely.
Sure.
Okay.
Very, very happy.
All right.
Thank you so much.
Thank you, ma'am. Thank you for gracing our webinar. It was a really very interesting and I have learned a lot. Thank you so much.
Thank you very much.
Thank you.
Thanks.
Okay. Bye-bye.
Thank you. Bye, ma'am.